like to introduce you to our speaker. Rachel Mutro is the Senior Program Director of the Missouri Telehealth Network and has been with MTM since 2002. Rachel is active in the National Telehealth Affiliation Groups and presents locally, regionally, and nationally on MTM projects such as Heartland Telehealth Resource Center and Show Me Echo. She works to secure funding for telehealth, advocates for legislative policy, and works with outside agencies to promote local, state, federal, and international telehealth activities and policies. Now I will turn it over to Rachel.
Thank you, Kim. It looks like we have a couple participants on. Feel free to send questions in or raise your hand at any time, and I'd be happy to stop what I'm saying and talk through any questions or make any clarifications. So, as you know, I'm the Senior Program Director at the Missouri Telehealth Network. You can find more out about our program at showmeecho.com if you'd like to go there. And there's my email address in case anybody wants to email me. And I have no financial disclosures. So I like to get started by talking about the mission statement of the Missouri Telehealth Network and then the Project Echo mission statement, just to show you how they overlap or align. So the mission of the Missouri Telehealth Network is to develop, study, and use telehealth solutions that improve access by providing high-value patient-centered health care and medical education in Missouri and beyond. And Project Echo's mission is to democratize medical knowledge and get best practice care to underserved people all over the world. So you can see how those two are well in alignment. Here at Missouri Telehealth Network, we've been around since 1994. We do a lot of training and education. We hold lots of training conferences and meetings. And our staff have expertise in the technical, clinical, operations, legal and regulatory, and also evaluation of telehealth programs. We operate through a wide variety of funding, including state funding, grant funding, and membership funding. We are one of the 3 states in the Heartland Telehealth Resource Center region, and with Missouri, Kansas, and Oklahoma, and we do get federal funding, a small portion of federal funding through that grant. As you can see on this slide, we have a pretty large team. We've got 14 people working on our project here in Missouri, and I do always tell people that it does take a pretty large operational team to make any successful telehealth project. So in Missouri, we've been doing telemedicine, like I had mentioned, since 1994. Telemedicine is really great. It does increase access, and it reduces the need for travel, but it does have limitations. And that limitation is that with telemedicine, you'll still just have one doctor taking care of one patient at a time. So one doctor and one patient, and then one doctor, and then one patient. So you are increasing access, but you're not really increasing the capacity for specialty care in your region. And that's where ECHO comes into play. So just a little bit of background about how we got started in ECHO. In 2013, there was a delegation of Missouri legislators that were going to New Mexico, and my medical director and I were invited to go with them to learn more about ECHO. We were just blown away with what we learned there, and so in 2014 we got Show Me ECHO put into statute, and we also got $1.5 million put into the budget to start Show Me ECHO. Unfortunately, that year the governor vetoed all new spending, but we were so excited about ECHO, we decided to get get started anyway. So we found other funding to start 2 echo pilots. One was with the Missouri Primary Care Association, and now it's the Chronic Pain Management Echo. And the other is an echo in autism care, and we started that with some grant funding from one of the managed Medicaid companies, as well as some internal funding that we had. So we got those 2 pilots started in 2014. And then when our legislative session came around again in January of 2015, we got that $1.5 million put back into the budget. It was it passed through and signed by the governor. And so we were able that year to expand on those 2 echo projects and have a total of 6 different echoes. And then the next year in FY 2016, we did get that bumped up to $3 million. However, we ended up with less than we had the year before because of budget restrictions. But at that same time, again, we became an Echo Super Hub, and that means that we can train other places in Echo. So if anyone on the call is from in Missouri or a nearby state, you can talk to us about learning how to create an Echo. And then this year in the legislative budget, we are back at the $1.5 million. But also because of all the work we've done, we were asked to be included and create new echoes for the state level response to the opioid epidemic, and we're looking at other types of state funding as well. So we're going to back up just a little bit to explain what ECHO is. So ECHO stands for Extension for Community Healthcare Outcomes. It's a telementoring project that creates communities of learning. If you look at that graphic, it'll show what I was talking about when I said there are limitations to the effectiveness of traditional telemedicine. So as you can see in the bottom part of that graphic, there's one little doctor there and then one patient. So they see one patient at a time. Whereas in the top part of the graphic, you have an interdisciplinary group, that's the Expert Hub. You have all of these learners at the spoke sites, those are primary care providers. And then you can affect a lot of patients for every hour of education and training that you have in an ECHO project. When we talk about ECHO, we often talk about this gap that's shown on this graphic. And that gap is between the fast pace of medical knowledge that is being gained every day versus the fairly flat learning capacity of any individual person. And so one of my colleagues had read that for a primary care provider to keep up with all of the new medical knowledge that comes out every day, they would have to read 19 journal articles every day. And that just gives you an idea of how much new medical knowledge there is. Now we know that with specialists, because they're only focused on one topic, they can much more easily keep up to date on all the new medical knowledge in their one field. So ECHO started back in 2003 at the University of New Mexico. Dr. Sanjeev Arora is a hepatologist, and in his Hep C clinic, there was a 10-month wait to see him. And so by the time people got to see him, they were much sicker than they needed to be. And so he decided that he wanted to figure out a way to do something about it. So he put together an interdisciplinary team with himself, a hepatologist, a pharmacist, a social worker, and a psychiatrist, because at the time the drugs caused depression in a fairly high number of patients. So he got them together, and then he went out and recruited primary care providers around the state of New Mexico and said, okay, who is willing to treat Hep C patients if you're partnered with me and this interdisciplinary team, and I can mentor you and we can work together to get these patients treated. And he got a fair number. He got probably about 20 to different people who said that they were going to partner with him. And so over time, they treated many patients under his supervision. So what happens in an echo is everybody joins on camera. It looks kind of like the Brady Bunch. And the participating providers, those primary care providers, present their Hep C case, just like they do in medical school. So they might say, I have a 43-year-old white male who contracted hepatitis C from a blood transfusion, and go through maybe 20 different data points about that case. So the case is de-identified, but they're describing the case. And then everyone gets to ask clarifying questions. They might ask something like, well, is the person still using alcohol? Or what are their family supports? To try to get an idea of their ability to stick with the treatment. And so the primary care providers get good advice, very specific advice on how to treat the patient. And then they might represent that case in 12 weeks to see how that case is doing. And so over time, each of those primary care providers are treating their own cases. They're learning by doing because it's their own case and they're getting all this new information. During each echo clinic, there's also a short didactic, maybe 15 minutes of lecture out of an hour. So most of the time is spent on case presentations, but there's also a short didactic. So after about a year, Dr. Aurora, actually I think it was 2 years, Dr. Aurora decided to go back and look at what were the outcomes of the primary care provider group versus his team at the academic medical center. And it turns out that the outcomes were the same. In fact, the primary care provider in the community, that group, had a little bit better outcomes. And they attribute that to the primary care providers having a better understanding of the social determinants of health for their own patients. And so they, instead of just having 2 cities in New Mexico that had physicians treating hepatitis C, suddenly they had 22. So you can, this goes back to my point that echo increases access, but it also increases capacity to care for patients with certain conditions. So once Dr. Aurora was assured that this was a good method, then he decided to see if it translated well to other types of disease states or conditions. So at this point, we describe echo as a hub and spoke model. And in this graphic, you can see the interdisciplinary team is all in the middle part of that graphic, and then we've got groups of primary care providers or clinics from all around the state in the other part of the graphic. But it doesn't mean that the only information or wealth of knowledge comes from that interdisciplinary group. In fact, the knowledge comes from everyone. And so the interdisciplinary team often learns from the primary care providers. Primary care providers learn from each other. And so everyone is benefiting from the time spent in the echo, including the patients, of course. So the ingredients that it takes to make a successful echo is that you have to figure out, you have to have a hub team that wants to share their knowledge. Not every specialist would be the right person to sit on a hub team. Maybe they would feel threatened by other people treating something that they were specially trained to treat. So you have to have someone that really is sort of a mission-based person that wants to share their knowledge. You have to find spoke sites that want to learn and share their cases. And so from the spoke site, you are a little bit vulnerable. I will give you an example of that. In the chronic pain management echo, the providers that are sharing their cases have to be willing to go over the long list of medications that they have provided to their patients. And in many times, they would think that they already know that they have their patients on too much medication. And so what we have done in that echo is to work really hard on creating a non-judgmental, shame-free environment so that it's okay to share that information. You also have to have an operations team. When I talk about this, a lot of time I have people think about a restaurant. So you know that when you go to a restaurant and you get that lovely plate of food, there are a whole lots of people in the back of the restaurant working hard to create that experience for you. Echo is the same thing. So the people that show up every week on that hub team on video, there are lots of operational details that take place behind that are very important. Of course, you have to have technology to run an echo program. You have not just video, but you have to have HIPAA secure database storage and other types of technology in order to run an echo. And then the O in echo stands for outcomes. We're going to talk a little bit more about that later, but you do have to, if you're going to start an echo program, you do have to be able to track the outcomes. So when Dr. Arora talks about an echo, he talks about these 4 tenets that really make up an echo. You have a lot of openness to create an echo however you want to, as long as these 4 tenets are part of it. So number 1 is the technology. You have to use multi-point video conferencing. You have to use best practices or evidence-based medicine to attempt to reduce variation in care. You have to utilize case-based learning, because we know that adult learners learn by doing, and you have to monitor the outcomes. Now, in the picture that I have on here, this is our dermatology echo, and you might be able to see in the background many different squares on that TV of the participants. And in this echo, Dr. Karen Edison, who is my medical director, is showing the participants how easy it is to do a skin exam to look for melanomas. And so the person that is in the picture, being the patient, is a coworker of mine who volunteered to play that role for the purpose of this training. But she wanted to demonstrate how easy it was to do a skin exam, because often in primary care, physicians don't take the shirts off patients anymore and look at their back and the back of their neck and the back of their ears. So kind of to reiterate more about what echo is, the specialists share their knowledge and they partner and mentor with community primary care providers. Those primary care providers care for their own patients with chronic conditions instead of referring all of them out. And then communities have the better or more capacity to care for their own citizens. There are echoes going on all around the world. It is really, really getting the attention of leaders in different healthcare organizations and different health systems, and we're seeing a lot of growth in the echo movement. Here in Missouri, we have asthma, autism, chronic pain management, dermatology, hepatitis C, child psych, substance use disorder. We're going to kick off in the fall, and healthcare ethics will begin next month. You can see that I have endo-echo crossed out on this slide, and that is because we tried really hard to start an endocrinology echo with the hope of improving care for diabetics in the state. We could not recruit primary care providers into that echo. We tried every way that we could think of to get interest in this echo, and we just couldn't. So we stopped it for now, and then we will revisit it again at some point in the future. And I'm happy to take questions on that. I got this map from the University of New Mexico. It just sort of shows where echoes are going on across the United States right now. I feel like it's pretty up to date. The blue dots are echo hubs, and you can see Missouri Telehealth right in the middle of the state. The orange dots are what's called echo super hubs. Again, you can see one here at the University of Missouri also. That means that we not only have a bunch of echoes going, but we've also been giving the blessing from the University of New Mexico to train new startups for echoes. So we have echo training programs every few months, and we've had people come in from several different other states outside Missouri to get trained, as well as us using that time to train our own folks here in Missouri. So if you think about how echo benefits primary care providers, especially in rural areas, I'm going to skip that first bullet on there because it's the next ones that are what we have seen from our surveys with our participants about why they join echo. So they don't join because we're giving away free CMEs for this. They join because they want to learn more about the topic. They want to be able to treat their patients more effectively. But what they really like also is the interaction, the collegiality that they have with other providers from around the state who are in their own situation. It introduces learning back into their workday, and I think that they really enjoy that as well. And we know that most of the specialists that are on our hub teams, they give out their cell phone numbers to all the participants on their teams, and that type of access to specialists from the primary care perspective is very valuable. And so this list, I really should put the no-cost CMEs at the bottom of this list instead of having it right at the top. These are quotes from one of our participants who is the only physician in the whole county in Missouri, and he has said things like, I'm prescribing better for my chronic care patients. I'm more confident that I'm doing the right thing. He said, like many people, I sort of get in a rut with my practice habits, and so the echo has helped him have better talking points. He said that he didn't know how to work up a Hep C patient, so by joining the Hep C echo, he's been able to do that. He also said it would be nice for the specialist to understand the perspective that they have in the rural areas, and that by having relationships with the specialist, he is able to show them his perspective. And this is, like I said, this provider is the only physician in the county that he's in, and he joins, I think, 4 of our echoes that we have going on. Now, echo also has great benefits for the whole health system. It doesn't just benefit patients, it doesn't just benefit the primary care providers, but it can really help the entire health system. I'm not going to read this whole list, and you'll have access to these slides after this. Echo, while I would say from my experience that starting an echo project has fewer challenges than a telemedicine project does, because you don't have to worry about credentialing, you don't have to worry about reimbursement. There are significant challenges to an echo, though. Number one, you have to worry about funding. You have to figure out how you're going to recruit participants, because they're not really incented to join an echo. Providers don't get paid to learn, they get paid to see patients. So figuring out how to get people to join has been a challenge for us. We've found that you have to have organizational support from both the hub and the spoke sites. The leadership has to buy into this program. Number 4 is one that we thought of on my team when we were brainstorming about this, and that is, in many professions, you go to school for that, and then you go out into the real world and start working, and you're good. You don't have ongoing education. But we know with the changing environment in medicine, you do need lifelong learning. You need to understand the changes in the environment. And so recognizing the mind shift for the need for lifelong learning is a challenge in this project. And then, of course, the time commitment. You have to stop what you're doing and go actively participate in an echo and present cases that you have to take the time to fill out. Some of the lessons that we've learned that I think are particularly important is that when possible, echo should be part of a multi-pronged approach to solve a specific problem. And I will give you an example of that. So in our asthma echo, the echo is not the only intervention that we're having with these providers. We also have a program called Asthma Ready Communities, ARC, where there are regional asthma educators that go into clinics and help them pull panel reports on their own patients and go over those panels so they can see what is going on with their entire panel. Most providers think they do a pretty good job of taking care of patients, but when they get those numbers in front of them, that makes them face a different reality. The Asthma Ready Communities teams also educate not just providers, but they educate school nurses and other case managers and other types of healthcare providers that would be involved in the patient. So that's a multi-pronged approach to the asthma issue. It's not just the echo. The second lesson that we've learned is it's okay to build virtual teams. When we first started this, we really thought everybody needed to be, all those experts needed to be in one room on a panel. But with our substance use disorder echo that we are building to start this fall, all 6 people are in different parts of the state. So it's okay to build virtual teams as long as you get people together in the room so that they can build a personal relationship with each other and build trust, and that they all are on the same, have the same philosophy in treating the treatment of the patients. Number 3 lesson is that it is essential to build widespread support. We have gone to every stakeholder imaginable to try to build support for these programs, and I think I have a list of some of them in a slide coming up. And then it's vital to budget for recruitment and evaluation, and those are things that you, if you're on a tight budget because of a grant or something, you might not have room to put it in there, but I would advise you to find some other funding to do the recruitment and evaluation. Just a couple examples of how the virtual teams are here in Missouri. So in asthma, you can see that one of the people on the hub team is a school nurse in Springfield, Missouri. Our environmental specialist is in Cape Girardeau. The pediatric pulmonologist is in St. Louis. And then we've got an asthma specialist and social work here in Columbia. This slide's a little bit hard to read. I think what I really wanted to show on here is that some echoes are every week, some are every other week, some are year-round, some are scheduled in blocks, but all of them take place over the lunch hour. And we have found that that is really the only time that you can get people to participate. This map shows how we've been able to spread the work around the state. So all those circle dots are where providers have been joining an echo. This one's pretty up to date. It's probably not 100% up to date, but you can see we're really starting to make some headway in training providers all over the state. We've got a big hole up there in the northwest part of the state that we're going to be working on recruiting providers from there. Just a couple slides on the evaluation for outcomes. We are looking at the Missouri Medicaid claims data for some of our topics. Some people are looking at subject matter knowledge, so they give people a pre and post test on the subject matter. The self-efficacy is one that we're doing for all of our echoes, and that is that you would do a pre and post test, and it asks you about whether or not you think or how much knowledge you have about a certain topic, and then how confident you are in treating patients with certain diseases. And so it's a little bit about the confidence of the provider. And what we've seen that's very interesting is that in dermatology and then endocrinology, certainly, the providers rate themselves really high before they start the echo. So they rated themselves very high in their knowledge of dermatology and their ability to treat derm issues in their patients. And then after a few months, we gave them that same survey again, and their self-efficacy goes way down. And we think that's so interesting, and we think it's because they learn what they don't know. Like, they think they know a lot, and then they start learning it, and they're like, oh my gosh, I really don't know very much about dermatology. So I'm not going to spend any time on this slide other than to know that we are partnered with some people here at the university and then people at our Missouri Medicaid department to take a look at the claims data to see if we can see behavior change in providers, such as are they prescribing different things now that they know more about the disease? And we would like to see behavior change in patients in regards to more appropriate use of the health system. So we want to see reduced emergency department visits. We want to see reduced hospitalizations. We want to see an increase in outpatient or planned visits. This is very preliminary data, but we have been able to show exactly what I was talking about. So we looked in asthma. We looked at 29 counties that had providers participating in ECHO, and we looked at the number of inpatient hospital days and emergency department visits for the year before we started ECHO and then for the year that we had ECHO going. And there was a huge reduction in the number of inpatient hospital days and a huge reduction in the number of emergency department visits. We got average costs per day in the hospital or per emergency department visit. We got those numbers from our Medicaid group. And the total reduction in 1 year was over $4 million. And we use this data to convince our legislators who hold the purse strings for our project to continue to fund us. We are looking at this data every 6 months to make sure that this wasn't just a blip, and this is only the very first run of the data. So we will be running this data again in July of this year. A little bit more about the self-efficacy studies. I already talked about this. I don't think there's anything else on there, but I would be happy to answer questions on that. The last type of data that we look at is the CME survey, and so because we provide free CMEs, every participant has to go fill out a short survey, and then on there's a place where people can enter in free text, and so these are some of the quotes that we've gotten from the CME surveys. So the CME surveys have been very valuable for us as we look to improve the ECHO process. So a couple things that make Show Me ECHO different than some of the other ECHO projects is that we really have a focus on recruitment and outreach. In fact, we have a person that's all she does is recruitment and outreach. We also have a focus on health literacy. We have a health literacy expert on every single one of our hub teams. We have a full-time evaluator, and then we have a large multi-stakeholder Show Me ECHO advisory committee. I told you earlier that we go around the state and build support for our program. These are a few of the organizations and partners that we've talked to over the past couple of years. Here is a list of some ECHOs that we're looking at for the future and trying to find funding for. Community health worker has been a big movement in Missouri, and we're really trying to work with the federally qualified health centers and other types of health systems to see if we can't get a community health worker echo up and running as a pilot and figure out how best to keep those community health workers engaged and up to speed and under the mentorship of some other professionals. The high-risk OB, we spend millions and millions of dollars in Missouri on high-risk OB moms and babies that are born early, and we think that we can affect those outcomes through an echo, and so we're trying to find funding to do a pilot in high-risk OB. And lots of other, you can see lots of other topics. It's almost like you can find a use for echo in almost any medical topic if you build the right team. And that is the end of my presentation, and does anybody have questions or want to have a conversation about any part of this presentation?
Thank you so much, Rachel. If anyone wants to use the chat box to type a question or a comment, otherwise you can press *2 to unmute your phone line. And Rachel, we'll just give folks a second here in case
Sure.
they have any questions. So Rachel, you mentioned that you're able to do the ECHO program in Missouri and surrounding states. Are other states available for ECHO programs as well?
So, Kim, I think what you're asking is about the super hubs status. And so we train, so most people when they get started with an ECHO project or they think they want to do an ECHO project, they go to New Mexico, and that's what we did. And we send people down there every single month. They do training down there. So you can go down, it's all free. You can go down there. You just have to figure out how to get down there and pay for your place to stay. But they offer that every single month. But they are really trying to take this movement. They have a goal of having ECHO touch 1 billion people by 2025. And in order to do that, they needed other training centers. So we are a training center for them, in addition to the training center in New Mexico. And there are other states that are doing that. So one is not a state exactly, but it's the American Academy of Pediatrics is the super hub, and they hold trainings in Chicago, and they've been doing that for a while. And then most of the other super hubs that have been really active are not in this country, but I think MD Anderson is now a training hub, and so they've held a couple training programs. The University of Chicago is a training hub. University of Wyoming is also a training hub.
Oh, okay, great. Thank you so much for clarifying that. That's great.
Hi, this is Jill from Arizona. Can you hear me?
Yes.
We just begun starting a Project ECHO here in Arizona. The first round went to the training earlier, or the end of last month, and we're partnering with our Arizona telemedicine program, which is also a telehealth resource center. And we are beginning with rheumatology, but hopefully we'll be expanding the services. And so I was really curious. I know you've got fund. I came on the webinar late, so you've got funding resources from a lot of places. Can you go through how you got some of your funding?
Sure, I can. Thanks, Jill. And I know the telemedicine people in Arizona very well, so I'd be happy to help you guys in any way I can. But the funding, most of the funding we have is from the state. We have $1.5 million, and with that we can successfully run 6 different ECHO projects. And the way that we have been able to do that is by finding legislative champions. And so all you need is one. It's better, I think, if they're in the majority party, but because they can actually get things done. And we have been lucky to have that in our state, and the fact that it wasn't just one person. We have now been able to build ECHO up enough in the state that almost every state legislator, if you said, do you know what Show Me Echo is? They would say, yeah, I've heard of it. It's something about healthcare, right? So they may not be an expert on it, but they have heard of it because we spend a lot of our time during session and when the legislature is not in session, talking to them, just educating them about it, and then showing them how ECHO works. So when they're in their home district, even from their home, they could join an ECHO, even for just 5 minutes. And we've done a lot of that. Just say, I don't need you to sit for a whole hour and watch this ECHO. Just sit and watch it for 5 minutes. And then what I was saying about funding is that once you start building your network of stakeholders and supporters, especially within not just the state legislators, but the other state departments, so your Department of Health and Mental Health and Social Services, and once those folks start understanding it, there are a lot of different block grant programs that they could write you in for funding for an ECHO. So I don't know about rheumatology, if states get any block funding from the CDC or anywhere from that, but there are block grants available, and that's kind of how we've done it, is by building as broad of a net of support as we can, and so that when there are opportunities, they think of us and they call us and they email us and say, oh, I have this idea for you, or I just came across this this money and we think that we would like to write it into our next grant proposal. Does that make sense?
Yeah, but I have one more thing. I'm wondering, does Missouri get state funding for your telemedicine programs? Because I think one of the concerns is that we're already getting state money for the telemedicine, and I don't know if we can go and ask for more money for Project ECHO.
We do, and we did. So
okay.
We get a pretty small amount of money. It's not even $500,000 for our telemedicine program, and we've gotten that for, I think this is our 12th year for that. But it's not that much money, and it's certainly not enough to run a bunch of ECHO programs. And so we were able to get them to add $1.5 million on top of that.
Great. Okay.
And part of it, I mean, there are lots of good arguments out there for ECHO, but economic development is something that Missouri's a largely rural state, and I would say Arizona's probably the same way. Yeah. But if you talk about ECHO and telemedicine, but ECHO particularly in regards to economic development, and then people get it. They really get that argument, because those patients can stay local and get all their health care locally instead of going to the big city and spending all those dollars in the city.
So are most of your dollars, are you paying your providers with your grant money?
So the funding goes to two pots. One is to pay that hub team. We pay them anywhere between 5 to 15% of their salary to help out on the hub.